Good morning, all the delegates who have joined us for this virtual meeting. Uh, this is a meeting from Indian Society of Gastroenterology. These are master classes by the masters of the subject. We started these meetings way back when there was COVID, and it was a tremendous success to start with. Then we had various series of such classes. Now we have entered to the fifth series of this master class. This is a program which is not only being attended by the PG students, but also the practicing gastroenterologists, the faculties at various medical colleges, and it's not only national but at international level also. The people who do attend these master classes, and uh, we are conducting these series at a monthly interval, and this is the fifth series of our master classes. Uh, this master class actually has a subject which is a little unusual, but it is very important for all of us. We normally deal with the garden varieties, and this time we are going into some lymphocytic disorders, lymphatic disorders, not only arterial venous, but lymphatic disorders. And we will look into also lymphangiectasia of the intestine. And for this, we have got two learned speakers with us. Dr. Samagr Agrawal, he is the faculty member, the assistant professor at the All India Institute of Medical Sciences. He'll be touching on the clinical aspect. Then we have Deva Senatipathy. He is the professor of gastroenterology, professor of radiology at All India Institute of Medical Sciences. He will be touching on how to diagnose these unusual cases. So we straight away we go to the first talk, which will be delivered by Dr. Samagr Agrawal. When to suspect, how to clinically diagnose these patients. So, Dr. Samagr, you are on.
Thank you, sir. Thank you so much for the kind introduction. I will be mainly talking we will mainly be organizing this talk around three basic heads.
Dr. Samagr, actually, I'd like to tell the delegates that if they have any question and answers, we'll take after the end of the two talks, and they can put their questions on the chat box so we can take those answers after the two talks. Yeah, carry on now.
Sure, sir. Sure, sir. So we will mainly be covering lymphatic disorders and how they are relevant to a gastroenterologist. We will be taking radiologist perspective from Dr. Deva. And finally, we will discuss a case and how we can manage such cases appropriately. So this is a common case scenario. A patient comes to you, he is otherwise well, has a normal BMI, he has only some reflux, all the lab routine parameters are normal. You perform a upper GI endoscopy and you find this. You find multiple whitish spots in the duodenum, and you somehow take a biopsy, and biopsy reveals this, the finding suggestive of lymphangiectasia. Now, what do you do next? So in the next few minutes, I'll try to cover a bit about the basics of lymphatic disorders and how they are relevant to a gastroenterologist. And in routine practice, how do we manage such cases when we come across them? So the lymphatic system is not something that is very closely related to what we do in gastroenterology, but it is important to understand that lymphatic system is just one of the very important parts of all the systems that we deal, and all of the diseases that we see usually have some involvement of lymphatic system in them. It is just that in patients with lymphangiectasia, lymphatic vessels are the primary source of disease. So lymphatic system is a complicated system. It has lymph, which includes lymphatic fluid and cells. It has lymphatic vessels, and it has lymphoid organs, which could be primary lymphoid organs, secondary lymphoid organs, including lymph nodes and spleen, and then tertiary lymphoid organs, which are gut, the mucosal associated lymphoid tissue, and the peripheral tissues. So the lymphatic vessels are something that we do not come across that frequently, but anatomically they are very much similar to capillaries, although there are some marked differences. Firstly, they are larger. They are almost 5 to 10 times larger than a standard blood capillary. It's a one-way conduit. It is composed of lymphatic endothelial cells. The endothelial junctions are different, the pericytes are different, and the basement membrane is different. And essentially, there is no pumping mechanism within the lymphatic system itself. And it's just that contractility of the smooth muscle cells and the surrounding skeletal muscles and the arterial pulsations propel the lymph. And there are multiple lymphatic valves that prevent lymphatic backflow into the lymphatic vessels. So lymphatic vasculogenesis in itself is only recently getting better understood, and it is a carefully orchestrated phenomena. The lymphatic capillaries originate from venous endothelial cells, and there is a very complicated pathway that ensures that the lymphatic vessels as well as the lymphatic valves develop appropriately. So you'll come across multiple of these transcription factors if you go into the detail of the lymphatic vasculogenesis. But it is important to just highlight here that there are multiple factors, the most important being VEGF-C and the VEGF receptor 3. And along with that, the lymphatic valves is also closely regulated. So, when we talk about lymph per se, the fluid that is flowing within the lymphatic vessels, it is composed of interstitial fluid. The interstitial fluid is nothing but something that seeps from all the blood capillaries and all the organs, and it comes into the interstitial fluid, and then it is taken up by the lymphatic vessels. The lymphatic vessels in this way act as scavengers of the lymphatic fluid, of the interstitial fluid, and ensure that there is maintenance of homeostasis and fluid does not accumulate within the tissue. Secondly, we have chylomicrons within the lymphatic tissue, and we'll see a little bit more in detail about this in the next few slides. And finally, we have the lymphocytes. While this is not the topic of our the something that we are discussing today, but it is important to note here that lymphocytes are very closely related to the whole lymphatic system once they are formed in the bone marrow and they mature in the thymus and the lymph nodes. So chylomicrons are essentially an end product of fat digestion in the intestine. So fat is a relatively complicated thing to digest for the body. The fat comes in form of a globule. There are multiple globule-like structures, and they form large fat droplets. So the body just cannot absorb fats like additional electrolytes. So first they have to be emulsified, and bile plays a very important role here. Emulsification is just breakdown of larger fat droplets into smaller droplets. Then they are hydrolyzed by enzymes. The most important enzyme here is the pancreatic lipase, but in case pancreatic lipase is not available in patients such as those with chronic pancreatitis, other lipase take over, such as gastric lipase and salivary lipase in different capacity. Again, we do not know very much about the proportion of contribution of these individual lipase, but they mainly break down three basic fuels that we have. So triacyl glycerols are broken down into monoacyl glycerols and free fatty acids. Phospholipids are broken down into lysophospholipids and free fatty acids. And cholesterol esters are broken down into cholesterol and free fatty acids. So once we have all these moieties, we have free fatty acids, we have monoacyl glycerols and lysophospholipids as well as cholesterol, then they need to be absorbed. And the absorption itself is a very closely regulated mechanism. There are four basic steps. The first is the uptake by the enterocyte. And then there is reesterification, because the internal compartment of the cell is full of hydrophilic material, and the hydrophobic fat droplets cannot be just absorbed. So they need to be reesterified. And then they are processed, and then they are absorbed. So when we look at the most important pathway, the free fatty acids are mainly absorbed by protein-mediated or diffusion pathway, and then they are reesterified into triacyl glycerol in the smooth endoplasmic reticulum. Finally, chylomicrons are formed in the rough endoplasmic reticulum and the Golgi, and these are then secreted into the intestinal lymphatics or lacteals. There's another pathway where the triacyl glycerols, especially the smaller triacyl glycerols, are just taken in directly into the cell, and they skip all these steps. This is more commonly known as the direct pathway, and it is most relevant for the medium chain triglycerides. We'll come into more detail very soon. There are a number of important proteins here that are involved. I'll just highlight those. So IFA-BP is a very important protein here, which takes up the protein and binds the proteins, and it is also an important biomarker. Microsomal transfer protein again is a important protein here, and in patients with A beta lipoproteinemia, it is deficient, and such patients do not form the chylomicrons as we know them. Finally, there is a very important protein here, ApoB48, which is incorporated into lipoproteins. And that again is a protein which is important. And in patients with chylomicron retention disease, ApoB48 is deficient, and such patients have defects with fat absorption. For cholesterol, the pathway is a little bit different. The NPC1L1 first uptakes the protein and then it reesterifies it into cholesterol ester in the endoplasmic reticulum. But later it is again secreted into chylomicrons and then secreted into the intestinal lacteals. The enzymes here are also different. For cholesterol, again, there is a smaller pathway, which is secretion of cholesterol as HDL into the capillaries. So all in all, if you want to take any one point home from this slide, it is that there are three major pathways. One is the chylomicron pathway, which takes up more than 90% of the fat absorbed in the healthy state. There is a HDL pathway that is mainly for cholesterol, and it is a redundant pathway. And then there is a direct pathway, which is for smaller triacyl glycerols. And this can again take up a little bit of fat, mainly the medium chain triglycerides, and these can be transferred. So there is a lot of redundancy over here. And you might wonder, why do we have these lacteals? So a lot of people have tried to give explanations. One is that there is redundancy in the pathway, and that helps in case one of the pathways is blocked. However, lacteals are evolutionarily conserved in all vertebrates, and it provides a link between digestive, metabolic, and immune functions. And it is now becoming more clear that a large number of allergens that we see are actually lipid binding. And these allergens are directly taken via the chylomicrons into the lymphatic system, and these then face the lymph nodes. And that is why a lot of lymph is redirected from the liver instead of liver and portal vein into the lymphatic system. So it may be key for maturation of immune system in early childhood. And it is now known that patients who have lymphatic dysfunction, it may lead to some antigen translocation into the liver, which may further promote hepatitis and liver fibrosis. So now we shift the gears a little bit, and then we talk a little bit about the lymphatic vascular disorders. The key to lymphatic vascular disorders is defective lymphangiogenesis, which is usually an inherited disorder. This leads to lymphatic block and dilated lymphatics, and these dilated lymphatics then start leaking, usually into the bowel, where they present as protein-losing enteropathy, or they can also leak into the ascitic fluid, where they may form chylous ascites, or they may leak into the pleural fluid, where they may lead to chylous pleural effusion. So it's the usual pathway of a primary intestinal lymphangiectasia, where inherited disorder may lead to defective lymphangiogenesis. However, there could be a pathway where acquired disorder may lead to lymph nodal disease and lead to lymph nodal block. So usually both of these factors are contributing in an individual patient. And again, as we can see here, the intestinal mucosal and the submucosa has a lot of lymphatics, which normally are not that dilated. But once the lymphatic block starts, the lymphatic submucosal lymphatics start getting dilated, and this can lead to leak of lymphatics and probably some mucosal inflammation, which may even sometimes lead to blunted villus formation. And finally, once these lymphatics get dilated in the submucosal space and the extra bowel serosal space, they may form large lymphatic channels with dilated bowel loops, which are visible on imaging. So essentially, we are looking, when we talk about GI lymphatic vascular disease, we are talking in terms of three major lymphatic disorders. First is primary intestinal lymphangiectasia. And then we have secondary intestinal lymphangiectasia, secondary to numerous disorders. And finally, we can have lymphaticovenous malformations. So what are the common clinical scenarios where such disorders can present? So there are three major scenarios where a gastroenterologist should strongly consider a lymphatic vascular disorder. The first is when you have, as we saw in the first patient, incidentally detected whitish spots in duodenum on endoscopy. The second is a patient who has malabsorption with anasarca. Anasarca in the terms of pleural effusion, or the patient has ascites or bipedal edema with thickening of the skin. And finally, you have certain syndromic disorders. We'll touch a little bit in depth about all of this. So What do you do when you have incidentally detected whitish spots in the duodenum on endoscopy? So first important thing to note here is that they are not that uncommon. So whitish spots may be present in 3% of all upper GI endoscopies. And if you look at a series where you include enteroscopies, where people have done motorized spiral enteroscopy, whitish spots or changes of lymphangiectasia may be present in 10 to 13% of all cases. And in 60 to 70%, they are histologically provable with dilated lymphatics. And there have been small follow-up studies which have shown that up to 70% persist up to 1 year later. The clinical significance here is unclear, but they may essentially represent an equilibrium state, as the clinical manifestations will start only when the GI protein loss will exceed the amount of protein synthesis ongoing in the body. So, when the clinical consequences only become evident when the GI protein loss actually exceeds the hepatic protein synthesis. So, the biochemical abnormalities that are very evident are hypoproteinemia. The patients usually have both decreased albumin as well as globulin. There may be lymphopenia in rare cases where there is a lot of lymphatic leak. There may be anemia and hypocalcemia because there is also a lot of fat malabsorption, which leads to vitamin D deficiencies and other vitamin deficiencies, which may lead to anemia. Finally, there is altered cellular immunity, and while there is no definite established test for such patients, a different test may show varying abnormalities in when we do them. These may present as various symptoms and signs, the most common being bipedal edema. And then some of them may have overt diarrhea when the amount of protein and fat being expelled exceeds the capacity of the colon to absorb. And then these patients may also have ascites, pleural effusion, and very rarely, if there is a lot of edema, some patients may actually develop retinal detachment. And the lymphatic fluid may accumulate between the choroid and the retina. So it is usually believed to be a rare disease. Primary intestinal lymphangiectasia has less than 200 cases reported up till 2016. A lot of these cases came from USA and Europe. However, it is important to understand here that these essentially represent cases which were evaluated once the clinical symptoms have started. And most patients achieve an equilibrium state with lymphangiectasia evident only on detailed evaluation, including enteroscopy. So there is a broad spectrum of clinical presentations. While a lot of patients may have normal bowel findings, and some of them may have genetic or acquired risk, a lot of patients may have no endoscopic findings, no laboratory abnormalities, and no clinical manifestations. And in 3 to 10% of patients, as we saw in the previous slide, endoscopic findings start appearing. And these usually appear as whitish spots that are visible. And again, these patients have no laboratory abnormalities and no clinical manifestations because they're essentially in an equilibrium state. Finally, once the patients progress further, they may have some laboratory abnormalities, and very few patients actually have clinical manifestations. And the complications and need for organ support may be even rarer in less than 1 in a million patients. To further complicate the matters, the genotype does not actually lead to any particular phenotype. So a person who may have a genetic defect may not actually manifest the phenotypic abnormality. And then there are other diseases that may further complicate the picture. So a patient may have a associated disorder of gut-brain interaction, or the patient may have some other disorder of malabsorption, which may further complicate the picture and make the diagnosis of lymphangiectasia difficult. So we do not know how many patients are actually having some minor laboratory abnormalities and clinical manifestations, and this could be a fertile ground for research. So further, when we talk about secondary lymphangiectasia, obstruction at any level in the lymphatic pathway can lead to lymphangiectasia. Dr. Deva will be talking a bit more in detail about this in his slides. So again, primary intestinal lymphangiectasia is believed to be a rare disorder, and a large number of disorders can present with one of the key manifestations, either protein-losing enteropathy, or they may have secondary lymphangiectasia. The protein-losing enteropathy may be without ulcers or with ulcers, and there's a wide list of differentials there. And secondary lymphangiectasia may occur due to obstruction anywhere along the pathway, which may include lymph nodal disorders, retroperitoneal fibrosis, cardiac or liver diseases, and rarely trauma or surgery. So, what do you do when you have a patient with suspected lymphangiectasia? So, first key here is to evaluate the clinical symptoms and the lab abnormalities. The clinical symptoms may include generalized edema and chronic diarrhea, which are the most common symptoms. However, some patients may also have additional symptoms as highlighted before. And lab abnormalities will mainly be characteristically having hypoglobulinemia as well as hypoalbuminemia. Lymphocytopenia is probably not that common. We usually routinely do not perform abnormal alpha-1 antitrypsin stool in the stool for diagnosis of protein deficiency, but that can also be done. So once we have established that there is protein losing enteropathy, we try to rule out secondary lymphangiectasia. How do we do this? We mainly focus on the history and rule out any cardiac issues. We rule out additional neoplasms that will be evident on imaging, and we take history that could suggest infections, and we also confirm it by performing a upper GI endoscopy or biopsy. In some patients, we may require additional tests, which includes capsule endoscopy and imaging workup, which may include MR lymphangiography and lymphoscintigraphy. Once this is done, we confirm the primary intestinal lymphangiectasia and we try to specify the location of abnormal lymphatic channels. A brief word about the syndromic disorders. The genetic disorders that occur as a syndrome are usually not the classical Mendelian inheritance that we are aware of. So while we know that a lot of genetic disorders may have inherited disposition or de novo disposition, most of the primary lymphatic disorders occur following somatic mutations that occur in the post-zygotic phase. And essentially, there is very rarely a family history that is available. And commonly implicated genes include the ones that we had seen before, the ones that are involved in lymphangiogenesis, as well as the formation of the valves. To further complicate the matter, there is an imperfect genotype-phenotype relationship, as we saw earlier. So while we are used to disorders which have complete penetrance, in the sense that a patient who has a FAP will have a APC gene mutation, these disorders are not that perfect, and there could be incomplete penetrance. There could be variable expressivity, where a patient who has the gene may not manifest all the manifestations and may manifest only some of the clinical manifestations that may occur. So these are the commonly described syndromes. The most common being the non-Milroy syndrome, which occurs following the VEGFR3 mutation. And the another common mutation that occurs in this spectrum of disorders is the PIK3CA related overgrowth spectrum. And these patients usually have a lot of manifestations. Important from a gastroenterologist perspective is that there could be lymphatico-venous malformations as well. And such patients may present with a GI bleed, as in seen Klippel-Trenaunay syndrome, or rarely they may also have a GI bleed due to blue rubber bleb kind of syndrome. There are other genetic syndromes also associated, which are rare, but again, should be on your radar once you're considering such a disorder. So how do we diagnose lymphangiectasia in these patients? The most common and the most important test here is to perform a good endoscopic examination and take duodenal biopsies as and when required. And along with that, histopathology is the most important set of investigations that we perform. So when you do endoscopy, you usually see one of three clinical manifestations in this. And so, for example, we can have multiple scattered pinpoint white spots as seen in this image, or we can sometimes see diffusely prominent villi, as we can see in this images, which have some whitish discoloration at their tips. Finally, we can also see very rarely these focal small whitish macules or nodules. These are also evident on capsule endoscopy and on enteroscopic examination. Once we do a histopathology, we usually see dilated lacteals. These are the lymphatic vessels, and they appear white as they do not take up any stain in the standard H&E stain. And they may be again mucosal or submucosal. And we may find some inflammation present with polyclonal plasma cells. And usually we do not see any villus atrophy, as this is a very late feature, and usually no major microorganisms are present. And histopathology is not very sensitive, as we saw that they are positive only in 70% cases, but this is 100% specific test. Lymphoscintigraphy is another test that can be performed, and it essentially relies on using additional lymphatic tests where a dye is injected into the web of the feet, and this is usually a technetium 99 based sulfur colloid. And this, again, if there is incompetent walls, it can leak into the bowel, and this can essentially indicates incompetent lymphatic walls and lymphangiectasia. This is a difficult test, and it is not frequently available, and it is also not very sensitive in this situation. But when it is positive, it is relatively specific for for a lymphangiectasia like disorder. There are also certain ancillary tests which may demonstrate protein losing enteropathy, where a technetium 99 labeled human serum albumin, or MDP, which is bound to plasma protein, may be used, and this loss can be demonstrated. Again, this test is not frequently available, and while it is sensitive for protein losing enteropathy, the specificity of this test is not very well known. Now I will call upon Dr. Deva, who will discuss the anatomy of lymphatic vessels in a lot more detail, and he will also cover a lot of tests that can be done in these patients.
Thank you, Dr. Samagra.
Go ahead.
Please go ahead, sir.
Yeah.
Okay, sir. So let me share the screen. All right. So thank you so much, Dr. Samagra, for the introduction, and thanks, sir, for the introduction. So I'll cover in the next 20 minutes or so, I'll cover the available options to image the lymphatics and some of the available options in the intervention radiology domain, which can be used to treat those lymphatic disorders. Okay. All right. So as Samagra told that the anatomy of lymphatic system is quite complex, and it forms a major pathway for the drainage of interstitial fluids, which are fused from the capillary networks and put back into their into the circulatory system. That's the main function of the lymphatic system. There are multiple subsystems available in the lymphatic network. For example, soft tissue lymphatics, which will drain the lymphatics from the upper limbs and the lower limbs. There is intestinal lymphatics, which will drain the chyle into the lymphatic system. Liver will have its own lymphatic subsystem, which will have rich albumin in it, and other lymphatic organelles like lymph nodes, etc., which we all know. And all these subsystems communicate with each other in a very complex way, and most of those systems will empty into cisterna chyli, which is located in the upper abdominal area in the retroperitoneum, and eventually that empties into the thoracic duct. And the thoracic duct courses alongside the aorta till the level of the carina, and it moves towards the left side and before emptying into the venous confluence. And one thing it's important to know that is that cisterna chyli is one of the largest lymphatic structure in the body, which measures around 7 into 12 millimeters in an adult. And why this is important? And it is important because this is the reason why cisterna chyli is the main target for any interventional radiologist if you want to get into the central lymphatics. So cisterna chyli is one important landmark structure which we should all know. All right. So apart from this, the lymphovenous connection, which is located here in at the end of the thoracic duct, which empties into the venous confluence of this left subclavian vein and the IJV, and there are multiple other lymphovenous connections exist, but this is the most largest of them and the most important of them. If you look at the lower limb lymphatics, this is the lower limb lymphatics on the right side, and this is the lower limb lymphatics on the left side. They all go to a caudocranially towards the torso, and they empty into the pelvic lymphatics and into the retroperitoneal lymphatics, and eventually all these lymphatics will empty into the systemic chyli. The structure is the systemic chyli here, which is located in the upper abdomen, and the systemic chyli would empty the lymphatics into the the thoracic duct, which will empty into the venous confluence. Here, this is the direction of the flow, which is important to know. And there are other subsystems like liver and the intestine, which also have their own lymphatics, and they also empty the lymph into the systemic chyli. So this is a normal anatomy or flow of the lymph, which happens in a normal individual. So whenever we try to image the lymphatic structures, the lymphatic anatomy using a lymph nodal injection from the inguinal lymph node, that will opacify the pelvic lymphatics, retroperitoneal lymphatics, systemic chyli, and the thoracic duct. Since the flow of lymphatics from the liver and the intestine is towards the systemic chyli, and most often in normal individual, the reversal of flow is not usually present in normal individuals. So we will not be able to see any of those lymphatics when you try to inject contrast from the inguinal lymph nodes. And that's the reason why these subsystems like liver lymphatics and the intestinal lymphatics are generally hidden from our routine view. Okay, so why it is hard to image lymphatics? The reason is there is lack of available robust techniques like we have in the evaluation of vein and arterial structures. Each of these subsystems needs different approach to demonstrate them. For example, like just now we talked about the retroperitoneal lymphatics and the systemic chyli, which can be opacified by putting a needle in the lymph node in the inguinal region, or putting a needle in the web space intradermally, injecting contrast into those areas. We can opacify those. Whereas the liver and the intestinal lymphatics or mesenteric lymphatics will not get opacified in those approaches. We need a specialist approaches to opacify those structures. Another challenging issue is to how to introduce contrast into those lymphatics. They are small, delicate structures. The anatomy is quite variable, and they are not usually easily picked up on imaging modalities. So it's very tough to introduce contrast into those lymphatics, and that makes it even more difficult to image them. And last is that the understanding about lymphatics is quite limited, even as of now, compared to other venous or arterial structures. So there's a long list of imaging modalities which are available with us when you want to image lymphatics. The first one, which is the conventional imaging like ultrasound, CT, and MR, they are not capable of showing the lymphatics. If they are grossly dilated, if there is a lot of congestion, it may show some amount of some features in those basic modalities. But for routine evaluation of lymphectasia or protein-losing enteropathy, they are generally not helpful. Sometimes we use heavily T2-weighted sequences in the magnetic resonance lymphangography. It can show the lymphatics in a good way, but the problem is it is very difficult to differentiate these lymphatics from the other static fluids like bile in the bile duct or pancreatic juice in the pancreatic duct, because they all look hyperintense on T2-weighted imaging, and that's the reason it is not quite helpful to differentiate lymphatics from non-lymphatic structures. Other two lymphatic imaging modalities like nuclear lymphoscintigraphy and pedal lymphangiography, these are present. These are available for a very long time, and these are not often performed because either they are tedious or difficult to do. Now that's the reason why we have in the last decade or so, we have a lot more imaging modalities which are better in showing the lymphatics, which I will discuss in the later slides. Okay, this was mentioned by Dr. Samagra that lymphoscintigraphy uses technetium sulfur colloid injected into the web spaces, and this is how it is visualized on the imaging. But the problem is the spatial resolution is poor. Even if you want to look at dilated lymphatics or look at a leak or the site of leak, nuclear scintigraphy will not be able to show the accurate location of the leak. It may show the collection of pool of extravasate contrast into the abdominal cavity or in the ascites, but where is it actually arising from is difficult to show on leaflet lymphoscintigraphy. And again, the lymphatics from liver and the lymphatics from the intestine are hidden from this particular modality. Another modality which is of traditional importance is pedal lymphangiography. This is a tedious thing to do because it needs a cut down of skin here and introduce the needle into the one of the lymphatics in the foot and inject contrast or lipidol as the contrast here into the lymphatics and do imaging. And this is a very good technique. If you are able to cannulate and inject contrast, it will show the lymphatic structures nicely. These are the thread-like structures or the lymphatic channels which are present in the lymphatic in the pelvic area, and these globular areas are nothing but the lymph nodes. So this is a good technique. It can show the anatomy properly. It will map out the entire lymphatic tree, but the problem is it is quite invasive and it is a time-taking process to do this investigation, and it is largely now replaced by something called intranodal lymphangiogram, wherein we inject contrast not from the pedal area, we inject contrast from the inguinal lymph nodes. We'll see it in the later slides. So this is one imaging modality which is recently described, and it is called as ultrasound guided intranodal lymphangiography. The contrast material used can be either lipidol or water soluble contrast or even gadolinium contrast, depending on the modality used. So the guidance modality which is used for injection of contrast or any contrast into the node is ultrasound in this particular case. So this is considered as a revolutionary imaging modality to image lymphatics because it opens up the new window for the thoracic duct and the central lymphatic evaluation. What we do here is we place a thin needle, which is around 21 to 26 gauge needle into the lymph node, and we inject contrast slowly into those lymph nodes. The injection rate would be around 0.5 millimeter per minute, because beyond that, the lymphatics will rupture or the nodal capsule will rupture, and it will and this procedure will be unsuccessful. And there is again a limitation. If you are using lipidol as a contrast, there is a limitation of volume of lipidol which can be used on each side. Here, both the sides are utilized. Right and left inguinal lymph nodes are targeted, and we inject contrast into those lymph nodes. And each side we should not exceed more than 10 ml of lipidol. This is a very good imaging modality. It provides very high resolution imaging of the pelvic, RP lymphatic, cystinoid chyli, and the thoracic duct. In fact, it maps out the entire central lymphatics, which upon which we can plan our therapeutic interventions. Again, it is important to note that in a normal patient or normal individual, the mesenteric and liver lymphatics are not usually opacified because the direction of flow is different in those areas. Okay, this is how a puncture of lymph node is done using ultrasound. This is the ultrasound image showing the lymph node. This is the lymph node here, and we can see this is the lymph nodal cortex, and this is the fat hilum, and we can put a thin needle into the lymph node. And this is the lymph node here. Once we ascertain that the needle tip is within the lymph node, we can inject any of the contrast, depending on whether it's using fluoro, we can inject lipidol. So if you are in an MR suite, you can inject a diluted gadolinium contrast. So you will see that the lymph node getting swollen, and you can see the contrast also filling within the lymph node, and eventually when the pressure exceeds a sufficient level, the lymphatics would get opacified. So this is how ultrasound guided inguinal lymph node intranodal lymphangiogram is done. So it is very good in showing the anatomy of the lymphatics, flow dynamics of the lymphatics, and if there is a leak, it can demonstrate it very well. It has become the standard road mapping procedure before any lymphatic interventions. Whenever we start to plan an intervention, we start with this kind of intranodal lymphangiography to map out the entire lymphatic tree, so that it improves our, it reduces the time to puncture any of those lymphatics or lymph nodes. It gives us a plan to go about this particular treatment. So sometimes even minor leaks, especially in pediatrics. In fact, we published a paper on lymphatic abnormalities in children, wherein we used lipidol as a diagnostic modality to look for any leak in patients with chylothorax and chylus ascites. And in many of those children, even without using any glue or any embolizing material, just the usage of lipidol proved to be therapeutic. That's because in the site of leakage, lipidol is known to cause inflammation and fibrosis, which eventually plugs the leak if the leak is small in size. This particular procedure is relatively safe. There is no issue, except there are two important contraindications or concerns in this procedure. One is, if you are using lipidol, then you need to keep track of the volume of lipidol you are injecting in each of the lymph nodes. It should not cross the volume of 20 cc. The reason is, more than that, the lipidol globules will enter into the pulmonary circulation, and it will cause embolization of the pulmonary vascular structures. In patients who are susceptible to respiratory issues, it may cause issues. Otherwise, the other most important complication is that in patients with right to left cardiac shunts, if you are using this lipidol as the contrast agent, the lipidol globules will enter into the systemic circulation and can cause embolism in the systemic organs. That's one contraindication we need to be careful of. So this is the image of intranodal lymphangiogram using lipidol, and this is the location of the right side inguinal lymph node, and this is the location of the left side inguinal lymph node. We placed a needle here, puncturing the lymph node, and once you inject contrast, this thread-like structure is nothing but lymphatics, and we can see multiple thread-like structures here, and on the opposite side also we can see multiple thread-like lymphatics. Eventually, they form the confluence here, and they form the RP lymphatics. We can also see other globular areas here. These are nothing but the lymph nodal stations. So it will map out the entire anatomy of the lymphatics. At the same time, it will also locate the lymph nodes. For example, if there is a leak here, we can target this lymph node and embolize it. So that's the utility of this particular technique. It maps out the entire biliary in one go, and which is very useful in both diagnostic as well as therapeutic scenarios. Liver lymphangiography is again a recently described entity, and it is mainly done to demonstrate any leak which is arising from the hepatoduodenal lymphatics, or in post-op situation where there is lymphoria, to demonstrate any leak in that area. Liver, you know, that which contributes around 50% of the lymphatic flow into the thoracic tract. It is rich in albumin, and this particular technique, which is liver lymphangiography, can map out all those lymphatics in the deep area of the liver. So what we do here is that we target this. This is the portal vein here. This is the portal vein. This dark area is the portal vein. This is the IVC. This is the hepatic vein, and we usually have this echogenic thing around the portal vein. The wall of the portal vein will have echogenic appearance, and that is where the lymphatics are located. We'll have to put a thin Chima needle into that particular echogenic area, and we have to inject contrast, like water-soluble contrast, into those lymphatics that will opacify the hepatoduodenal lymphatics like this. Multiple thread-like structures which are emanating from the liver, and they are and flowing towards the duodenum. This is an example from the literature, and showing lymphatics going towards the duodenum, and in fact there is some leak into the duodenum as well in a patient who was having protein-losing enteropathy. So this is how a liver lymphangiography is done. And in patients with lymphangiectasia or any obstruction in the thoracic duct, which causes dilatation of the periportal lymphatics, the lymphatics are congested here. And in those patients, this echogenic area may be interspersed with hypoechoic areas. They're nothing but the dilated lymphatic channels, and which makes our puncture of those areas easier, because you have larger, thicker lymphatic vessels to puncture. And this particular procedure can be done under fluoroscopy or under MRI. If you are doing it under MRI, you have to use gadolinium-based contrast instead of iodinated contrast. Mesenteric lymphangiography, as I told you, mesenteric lymphangiography is another enigma within the lymphatic system. It is very hard to opacify these areas through traditional approaches. When you inject something through the inguinal lymphatics, it will not get to the mesenteric lymphatics. And it is always considered as a blind spot when you are doing the evaluation of central lymphatic channels. And there are methods available to opacify the mesenteric lymphatics, although all of them are tedious, tough, and it is really difficult to opacify those. Nonetheless, the approaches can be accessing the mesenteric lymph node. Like we inject contrast into the inguinal lymph node. Similarly, we can find a mesenteric lymph node and place the needle there and inject contrast into those. It will opacify that segment of mesenteric drainage and reaching up to the cisterna chyli. Or else, if you're not able to find any mesenteric lymph node, then you can inject contrast into the mesentery or the bowel wall, which will eventually get into the lymphatic system, which can also be imaged. There are a few case reports or even a series which was published, which they used a different approach. For example, they promoted the reflex of chyle or in the central lymphatic system into the lymphatics, mesenteric lymphatics, by blocking or balloon blocking of the thoracic duct. Uh, when you get into the thoracic duct and inflate a balloon there, it will obstruct the flow of lymphatics towards the venous confluence. That will promote reflex of contrast into the mesenteric lymphatics and the liver lymphatics. So when you inject contrast, it will opacify because the power flow is blocked. Now the contrast will reflect into the mesenteric lymphatics and the liver lymphatics. If there is a leak or an abnormality, it will be seen. But this is still an emerging technique, and there are very few literature available for this. Okay, so now all we talked about the modalities which are usually done under fluoroscopy. Now we'll talk about a technique which we do it under MR, which is called as intranodal dynamic contrast MR lymphangiogram. It was first described in 2014. It has become very popular in a short while. The reason is it gives an immense amount of information about the anatomy of the lymphatics, and the another important aspect of this particular modality is that it can opacify the central lymphatics in real time. But while doing the MR, you can inject contrast at a particular rate using diluted gadolinium and saline. It will opacify the lymphatic vessels in real time, and with the MR, you can see cross-sectional imaging, like images like axial, coronal, or sagittal, or 3D images, whatever you want to do. You can image all those using this particular technique. So once the contrast injection is done or being done, serial scans are done for the abdomen and the chest to map out the entire lymphatic tree. We inject contrast on both sides of the lymph nodes so that for the better opacification of both the pelvic and retroperitoneal lymphatics. The key point here is that correct placement of the needle tip inside the lymph node, because since the patient will be inside the MR gantry, and we have to ascertain that needle tip is properly placed. How do we check the needle tip? After the placement, we just have to do a check injection of the saline or ultrasound contrast agents that will swell the lymph node, and we can visualize it on the ultrasound scan. So this is the way we do intranodal dynamic contrast MR lymphangiography. This is one of the most commonly done lymphatic imaging in our department, because this is a diagnostic modality which gives a lot of information to us to either to diagnose or to plan any intervention further. It is a very safe procedure. There is no specific contraindications apart from the general contraindications of the MR procedure itself. So this is an example of MR lymphangiography. And in this particular patient, we injected contrast from bilateral inguinal lymph nodes. And once the contrast is injected, we can see that the pelvic lymphatics are getting filled up on the right side, on the left side, and little bit on the left right side also. And we can also see in the coronal images that we can see the retroperitoneal lymphatics, which is getting opacified. So this is how it is done, and these are the axial images of the same. We can see that pelvic lymphatics and the retroperitoneal lymphatics, which are seen going alongside the iliac and the IVC and aortic vessels. In this particular patient, there was leak which was happening from the lateral pelvic wall. This is the location of the lateral pelvic wall. And once you inject contrast into those lymph nodes, the leak of contrast happened from the lateral pelvic wall. And over a period of time, these are delayed images. Over a period of time, these contrast extravasation slowly seeped into the ascites, and we can also see the collection of contrast in the pelvis. So this is how MR lymphangiography by injecting contrast into the lymph nodes can be useful in both mapping out the anatomy and also in showing the leak in these patients. So what if we are not able to find a suitable lymph node in the inguinal lymph node. The other option is to inject diluted gadolinium contrast along with a local anesthetic, which is intradermally injected into the web spaces, and which is followed by cough exercises to promote the pumping of lymphatics. And by this method also, we would be able to see the central lymphatics. But the problem is it is a time-taking modality, and there will be a lot of venous contaminations. That's the reason why the images are not so good when compared to the inguinal intranodal injection techniques. So this is another image from the literature showing that this is how the injections are made in the F spaces. This is a diluted gadolinium here, and this is how the lymphatics are visualized on this particular technique. So coming to the interventional radiology treatment methods, there are many types, many things are available, but I'll touch upon one few important things relevant to the gastroenterologist. So let's start with a sclerotherapy for lymphocyl. Any post-operative scenario or collection in the post-op scenario can be a lymphocyl, which is nothing but a walled off thing which has the collection of lymph inside. So one of the techniques which can be used to treat this is sclerotherapy. Apart from this, most of them are generally treated with conservative approaches. But if it is not tackled with conservative approach, sclerosant injection is one way to tackle them. We put a pictal catheter, drain the lymph out, and we'll do a cavitygram to see the shape and other findings on the cavitygram, and we inject sclerosant, either alcohol, STS, or betadine into the lymphocyl cavity, and we give the dwell time of around 20 minutes so that the entire the lymphocyl wall gets obliterated. Even if there is a feeder from the lymphatic channel, even that would get eventually obliterated. So this particular procedure can be repeated multiple times, and eventually when the output of the collection is less than 10 ml per day, the pigtail can be removed and the patient gets better. So if when you do a cavitygram and if you're able to see a lymphatics, you can even get into the that particular lymphatic channel, and you can do glue embolization of that particular duct also. So next commonly done intervention here in our department is thoracic duct embolization. This is not so important for the gastroenterologist because this is mostly done for coilothorax. So if there is a leak or traumatic leak from the thoracic duct or anywhere in the chest, the go-to modality here is to block the thoracic duct, and that particular procedure is called as thoracic duct embolization. This is not so relevant for a gastroenterologist. Just wanted to mention that this is also one of the thing we can offer. The next thing is lymph nodal embolization. This is performed for most of the abdominal leaks. Whenever there is a leak which is happening from one of the lymphatics in the abdomen, we can do this embolization. We first do the MR intranodal injection using MR lymphangiogram. We'll map out the lymph channels. We also most likely will find the location of the leak, and we take the patient for intervention. We do a lymphatic lipidol injection in bilateral lymph nodes to map out the lymphatic structures and to plan which particular lymph node should be targeted. The idea here is when there is a leak which is happening here, for example, and there is a lymph node here in this location. So what we do is that once we map out there is a lymph node here and the leak is happening here, what we do is we'll puncture this particular lymph node here and we inject glue into that so that the lymph node gets sealed and even the lymphatic duct gets sealed, so the leak is prevented. The key here is that you should embolize the upstream lymphatic channel or the upstream lymph node, not the other way around, because the flow would be then will be problematic. So that's how we do lymph nodal embolization. And this is another example of the same patient discussed in the earlier slides. So after this particular procedures, we went on with the intranodal lipidol injection. This is a lymph node which is enlarged here, and we can see thread-like things like this are lymphatic channels, right? These are lymphatic channels, and we can see another lymph nodal station which is located in the external iliac location. And further in the delayed images, we can clearly see that there are blobs of contrast which are extravasating from the lymphatic channels. These are neither normal lymphatic channel nor the proper normal lymphatic and not normal lymph nodes. So we know that this is where the leak is happening, and we wanted to, the option is to either embolize this particular lymph node to seal the lymphatics. But since the patient was a child and the child responded just to the injection of the lipidol, and the child was better. So we didn't have to inject any glue. And then if you had to inject glue, this is the target, because here the leak is happening. So we can target that particular lymph node here, so that the leak from here to here will be blocked. So this is another example of a patient who underwent a surgery for a suprarenal lesion, and after the surgery, these are the clips in the surgery. Because of the surgery, there was chylous ascites, and this patient also we did the usual MR and the intranodal lymphangiogram, and eventually we found that this is the location of the leak, and these are the post-operative clips which are seen here. And when we injected intranodal lipidol into the lymph nodes, and we can see this blob of contrast, which is quite abnormal, and this blob of contrast was getting bigger and bigger. That's where the leak is. So what we did was we targeted the lymph node just proximal to the extravasation, and we injected glue into that lymph node, which took care of the bleed there. This is my last slide. So when we are dealing with protein-losing enteropathy in patients like Dr. Samagra discussed, one of the option is to block the hepatic lymphatics, because there is high flow of the liver lymphatics from the liver towards the duodenum before entering into the cisterna chyli, and because of that, there will be rupture or lymphangiectasia or ooze of lymph into the duodenal wall, or into the lumen, or into the peritoneum. So this can be dealt by injecting contrast. First, the diagnostic check into the periportal lymphatics. If you find any a leak from the hepatoduodenal region, or any abnormality in the region, and we can inject glue through the same needle, which will obliterate those channels, and it will cause block of those channels, and the leak from the duodenum will be stopped. So again, here the direction of the lymphatic flow is important, and it is only helpful if the direction is from the liver towards the duodenum. We can block the lymphatics which are taking the lymph from the liver to the duodenum. If we block that, the duodenal leak will get sorted out. So thanks for the time, and let me hand over to Dr. Samagra for further discussion.
Excellent, Deva. I think Samagra and Deva did an excellent job of going from the basics to the therapeutic aspects for treating such an uncommon disease. There are a few questions which have come to the chat box, so we'll take them one by one. And after that, I'll ask Samagra to actually give one case scenario, and then we'll discuss it further. The first question is how is the incidence of filariasis and chyluria in these patients of lymphangiectasia? So, Samagra, any comments on that?
So, from as far as I understand, filaria is restricted to the limb lymphatics, and it's the worm that cannot transfer to the GI lymphatics. And I'm not aware of any cases that have been come up till the GI tract. However, Dr. Deva, are you aware of any such case of?
No. I have not come across any of those filariasis affecting the GI. We have seen a couple of cases of the inguinal lymph nodes which get affected by the filariasis, because the virus or this parasite gets into the lower limb because of mosquito bite. So
Yes, sir.
Yeah. There was one more question. What to do of incidental lymphangiectasia? How to actually approach? I mean, the first slide you showed, in which actually patient had some dyspeptic symptoms and nothing else, and you find some telltale signs to say that it is duodenal lymphangiectasia. Now, how to approach these patients? Should we leave it as such, or should we go further for investigations?
Yes, sir. So, from what I understand and the review of literature, what I could do was that most of these lesions represent an equilibrium state. That in most of these patients, the amount of protein and the lymph that is getting lost because of lymphangiectasia is actually the same as the protein synthesis that is occurring. So it is a compensated state in a way. So per se, if a patient does not have any malabsorption, does not have any lab abnormalities, there is probably not a big case for investigating these patients further. However, these patients need to be on follow-up. And a study has shown that up to 70 to 80% of patients continue to have such lesions even at 1 year, 2 year follow-up. And we'll discuss the clinical course of these patients further. However, for most of these patients, important thing is to rule out malabsorption. If no malabsorption, probably a strategy of not doing anything and careful follow-up may be the right strategy here.
And there's one more question related to this only, that if somebody is having dural endoscopic findings, then what are the principles of doing the biopsy actually? Do you use a spiked biopsy, non-spiked biopsy? And as you have already said that the histology may not be there in spite of presence of the endoscopic findings. So there are any tricks to actually improve to get the histology findings?
Yes, sir. So, if you find a lymphatic vessel, if you find a white spot, then it is prudent to take biopsy exactly from that spot. I do not think a spiked or a non-spiked biopsy makes that much of a difference, although a non-spiked may increase the tissue yield in certain cases. And the important thing is to write on the pathology form very well that please look for lymphangiectasia, because they look like purely clean channels, and most of the cases of lymphangiectasia that we see are actually visible, but the pathologist does not report them because there is no clinical suspicion there. So if you're clinically suspecting anything, always mention on the pathology form that you are suspecting this, and probably it will be picked up. That's that. I'm not aware of any biopsy schedules or a biopsy protocol that may increase the yield further, but a standard four quadrant biopsy should be enough.
The question, Dr. Deva, actually, gadolinium or lipidol, which is better to close the small leaks?
Leaks, Dipidol is the best one to close the leak. Gadolinium will not cause any closure of the leak. Gadolinium-based thing is completely diagnostic procedure. We don't expect that to seal the leak, whereas a lipidol can function both as a diagnostic as well as a therapeutic thing, because the lipidol, when it gets out of the lymphatic system in that area, it can cause fibrosis and granulation reaction there. And this is what the hypothesized thing for lipidol, why it causes blockage or sealing the leak. Because as I said, we have experience in multiple patients where with just a diagnostic intranodal injection of lipidol took care of minor leaks.
Which is the best modality for imaging in such situations, actually? If you are suspecting a lymphatic obstruction, so you have told so many modalities, which one is
Yes,
the best?
sir. Right, sir. So normally in any of those cases, whether it is traumatic or a leak or even lymphangiectasia, the best way to start is to start from the MR, dynamic contrast MR lymphangiogram. So that will give the advantage of both visualizing the lymphatics, map out the entire anatomy, and also to give an opportunity to look at the cross-sectional structures. So we'll get the entire information, diagnostic information about the abdominal structures, the lymphatics after opacification through injection, and if there is a leak, everything can be picked up on MR. So once you have a lead based on the MR findings, then we move to a therapeutic option if it is feasible. So once you have the option of therapeutics, then we again start with, when the patient is in the interventional suite, we start with intranodal injection of lipidol. That will give us good information on, again, the map of the lymphatics and the lymph nodal stations, and also the cysternal chyli. So depending on which area we should target, we can, if you want to get into the thoracic duct, we have to go through the cysternal chyli. So which will be filled up with the lipidol by the injection we did just before the procedure, right? So that's how we generally start with MR. If we have the therapeutic intent, go with intranodal injection of lipidol, and then take it further depending on the situation. Yes, sir.
Dr. Sumagra, there is a question that if there is a suspected lymphocele, then what will be the characteristics of the fluid which we aspirate?
So again, sir, it is very variable. The lymphocele that we traditionally see should ideally have predominantly lymphocytic fluid, and it may be whitish appearing, but that is not always the case. It may have elevated triglycerides. Again, it depends on the equilibrium, essentially, that how long has the cystic collection been there, and how long has it been, and what is the mechanism of formation. You may find high amount of lymphocytes, you may find high amount of triglycerides, but none of them is like confirmatory or helps rule out a lymphocyte in this scenario.
Yeah. And there's one more question in the chat box, that is there any role of EUS
Yes, sir.
in GI lymphatic disorders?
On EUS, we have been able to localize thoracic duct in some of the patients, and we can see the lymph nodes, obviously. But to my understanding, I'm not aware of any interventions that are routinely performed or that can be done in such patients. Occasionally, if we if we have dilated lacteals or a very dilated lymphatic channel, that may be visible on EUS as a submucosal lesion. But again, I have almost no experience here, and I'm not sure that there is a very standard method of doing anything in this situation.
I think it can
Um,
open up a window for mesenteric lymphatics, because the view from inside, and if you're able to see the lymph nodes, maybe you can inject lipidol or contrast into those lymphatics. It may give
Yes,
good information on the mesenteric
yeah,
lymphatics,
EUS
because
gives a
that's
very
one
good
area we
image.
struggle.
yes,
Because
sir.
EUS
that's
gives a
one area
very good
we
image of the
struggle.
lymph nodes, so you can actually, puncture the lymph nodes very specifically on those areas. And
Correct.
there's one question regarding the if lipidol causes fibrosis, does this cause fibrosis in normal lymphatic after injection of during lymphangiography?
No, 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 no. The epithelialized vessels are not blocked. It is a very thick immiscible contrast. So the movement is also slow, but it does not. That's a transient obstruction. It will cause because of the slow this thing. But eventually it will pass through the lymphovenous communication. It will get into the systemic circulation, but it does not cause obstruction of the normal lymphatics.
And Samagra, there is one more question, like if we are suspecting duodenal lymphangiectasia, then maybe in overnight actually feeding with a high fatty diet and then doing the endoscopy the next day, does it helps?
Yes, ideally it should help. So, the fatty meal should help increase the diagnostic sensitivity of in patient with lymphangiectasia. But again, it's more of an anecdotal report, and I'm not aware of any other evidence beyond anecdotes that it may increase the diagnostic yield here.
Dr. Deva, there is a question like lipidol or lipidol plus glue for the leaks, which is better?
So depending on the situation, I mean, in children, pediatric age group, just injection of lipidol can take care of the leak. But if the leak is too much, it is not responding, then in the next session, we'll have to target that lymphatics or the lymph node using a glue. So the one aspect of glue is that we have to be as close to the leak site. The injection of lipidol can happen from a far away site, but when you are planning to do using glue, then it has to be just proximal to the site of the leak. So in difficult cases, and in most of the situations, we would end up using glue, but sometimes in small leaks, lipidol can take care.
Magar, there are one or two questions on actually secondary lymphatic obstruction, secondary to tuberculosis or Crohn's. So how can you differentiate the two? Can you?
I think it's a very difficult area to actually demonstrate, first of all, that there is a lymphangiectasia in these patients, and then to differentiate if it is because of TB or Crohn's. I think it's a totally different discussion altogether. But in all pathogenesis of TB-related diarrhea as well as Crohn's-related diarrhea, lymphatic obstruction may play a major role. But again, it's a different topic altogether. So.
And there's one question arising on the management part, role of octreotide and
We'll cover the
other
management
drugs.
in the next section, sir. We'll
Yeah,
cover the
I think.
management after the case.
Yeah, yeah. So this completes the questions from the chat box. So let's go to the next case.
Sure, sir. So, we have a case here, an interesting case scenario where we'll be able to see how the in the involvement of radiologist as well as gastroenterologist helps. So we have a 33 years old male patient who has diarrhea and weight loss. The diarrhea is predominantly small bowel, and there is no fever, no large bowel symptoms, no blood in stools. There is no lump. On investigation and evaluation, the patient is found to have only ascites. And the key here is hypoproteinemia. The patient has low albumin as well as low globulin. So once you have a patient who has low albumin as well as low globulin, the first thing that should strike your mind is this patient having a predominant GI disorder? Because globulin is predominantly not secreted by the kidneys, because globulins are large molecules and they're not easily filtered by the glomerulus. Further evaluation was done, and it was established that there was no impaired protein production. The liver function tests were essentially normal except for low albumin and globulin. Hemoglobin was normal. There were no major micronutrient deficiencies. There was no increased catabolism there was no inflammation as such. There was only lymphopenia on the DLC, and the total leukocyte count was normal. There was no clinical background that suggested a malignancy. And even though the picture was not suggestive of renal loss, we still did a renal function test. We performed 24-hour urine albumin, and all of them were normal. Fecal elastase was also normal, although this is a test that would probably not be very useful in this setting. So I will now call upon Dr. Deva to take this discussion further, that how did imaging help in this case? Dr. Deva, sir.
Yeah. So we started with CT scan, and now here the CT scan would show. Let me choose the pointer here. Sorry, no issue. So I am not able to find the pointer. Anyway, so here in the CT scan here, in the contrast enhanced CT scan, there is mild ascites here. We can see that in the left paracolli gutter and the right paracolli gutter. Apart from that, there is mild congestion or wall thickening or fold thickening in the proximal jejunal loops. That's also present, and there is wall thickening, which is stratified kind of wall thickening seen in the duodenum. This is the second part of the duodenum in the first slide, and this is the geno of the duodenum here, which both of them show a stratified kind of wall thickening. So next slide, please. Yeah, and there is associated bilateral pleural effusion, which can be present in hypoalbuminic state. So this is again the sagittal and the coronal sequence of the same, which essentially shows the stratified appearance of the duodenum, wall thickening of the duodenum. If you look at the mucosa is the innermost lining, and beyond that also we can see hypodense linear areas. In this given scenario, we would tempted to think that these are lymphatic channels, but it's a very difficult observation on CT to make. But definitely there is thickening and hypodense areas within the wall of the duodenum, especially in the D2 part. And with the background of this protein loss and the suspicion of protein losing enteropathy, we also went on to do a post-contrast imaging of using MR. And again, here also we can see that this is the duodenum, D2 part of the duodenum, which is significantly thickened, and there is hyperintensity of the wall of the duodenum. If you look at the wall of other bowel loops, they are not so hyperintense. But if we look at the duodenal part, it is quite hyperintense and thickened. And so we are even in the post-contrast images, we can see that stratified kind of wall thickening in the duodenum. Next slide. So we did, as a next step, we generally start with MR dynamic contrast, MR lymphangiogram, wherein we inject contrast, diluted gadolinium contrast from bilateral lymph nodes. So here we can see this is the right pelvic lymphatics, and in the further images, we can see that the retroperitoneal lymphatics are getting filled up. And progressively, if you look at the third image, we can see that after about mid-level in the retroperitoneum, there is diversion of this contrast towards the liver. We can even see lymphatics which are filling up in the within the liver also, which is not a normal finding which is seen. In a normal individual, the flow happens from the pelvis, the RP, cisterna chyli and then towards the thoracic duct. Whereas we are not able to see the cisterna chyli clearly, and also the thoracic duct is not seen here at all. So that's conspicuously it is absent here. At the same time, there is diversion of this particular lymphatic flow into the liver, and we can see that there is a layer of hyperintensity which is going towards the heart. That is nothing but the lymphovenous communications which have opened up in around the liver to, I mean, because lymph has to eventually get into the venous circulation. So that's the lymphovenous thing which has opened up. So point here is there is definite dilatation and abnormal lymphatics seen in the hepatoduodenal area. The cisterna chyli is not clearly seen. Thoracic duct is definitely not seen here. We can't say it is absent. Maybe there is obstruction. We don't know. But there is non-opacification of the thoracic duct. That is one clear-cut finding. And abnormal direction of flow and congested lymphatics from the duodenal side to the liver. Yeah, so like I said, the next point of thing would be that with the intent of embolizing, if there is any abnormality seen, we went on with the lipidol injection into bilateral lymph nodes, and here we can see injection of lymph nodal injection of the lipidol, and multiple retrobundal lymphatics and pelvic lymphatics are getting filled up. In the third image, we can see that now, instead of this RP lymphatics forming the cisterna chyli and forming the thoracic duct, it is actually getting diverted towards the liver. So definitely, there are the thoracic duct is absent, and that's the reason that the lymphatics are getting diverted towards the liver and eventually draining into the lymphovenous communications. So there is definite abnormality here. So what are the? Do we have the another slide or? Okay, yeah, better visualized here. So clearly demonstrating a large dilated hepatoduodenal lymphatics. These are quite abnormal looking lymphatics here. And if you look at the thin thread-like thing, which is getting more cranially, that's the exit point. Yeah, normally there has to be a straight line from the retroperitoneum towards the heart, but here it goes towards the liver and then and through a collateral channel, it is finding a collateral pathway to get into the venous structures. So quite abnormal looking lymphangiogram, and the more importantly, the direction of the flow is quite abnormal. Normally, the liver should empty towards the move towards the duodenum. Here, it is happening the other way around. The retromedullary lymphatics are being diverted towards the liver. So here, if you want to think of, this is one graphical image of showing the connections. Here, the lymphatic thoracic duct is not getting filled up. Maybe there is a block, maybe it is dysplastic, or maybe there is a stricture, and that's the reason the retromedullary lymphatics are being diverted towards the hepatoduodenal lymphatics, and eventually, because of the increased pressure, it leaks into the duodenal wall. So here that the diagnosis would be protein losing enteropathy is there based on the clinical thing, and it is probably secondary to focal duodenal lymphangiectasia. We can see dilated lymph channels in the area of the duodenum, and that must be the cause of protein losing enteropathy. So the diagnosis here would be protein losing enteropathy due to lymphangiectasia. Over to Samagra, please.
Yes, sir. So once we have this kind of a picture where a patient is actively losing lymph from the bowel, and the lymph is getting lost in the form of proteins, in the form of fat, and everything is getting lost in the bowel, and the equilibrium is disturbed such that the patient starts manifesting hypoalbuminemia and hypoglobulinemia. What do we do next? So the cornerstone of management for past 2 decades has been MCT diet, which is the medium chain triglyceride diet. So when we talk about fats and oils in the diet, there are essentially multiple types of fatty acids that can occur. We have short chain fatty acids that have less than 8 carbon atoms. We have medium chain carbon triglycerides and long chain triglycerides. Most of our diet is mainly consumed of long chain triglycerides, and these include the saturated fats, the monounsaturated and polyunsaturated omega-6, omega-3 fats that constitute the essential fatty acids as well. However, as we saw that a large amount of long chain triglycerides has to be broken down, and it requires a lymphatic pathway for absorption, and it forms chylomicrons which are essentially directed into the lymphatic system, and that is a major site of pathology in patients with lymphangiectasia. So the whole idea of using long chain triglycerides in the diet does not work. So we have to rely on something known as medium chain triglycerides. The most common source of medium chain triglycerides is coconut oil and palm oil. Some whole dairy in the form of yogurt or butter can also contain a decent amount of medium chain triglycerides. Now, it is important to note here that a medium chain triglyceride diet is also a very common fat diet, and a lot of people use it for weight loss, and apparently it induces ketogenesis and allows a lot of lipid fat breakdown in the body. However, it is not a healthy diet in patients who are otherwise who have a normal absorption system, because none of the essential fatty acids can be delivered by the MCT diet. However, in patients who have intestinal lymphangiectasia, they usually do not have any other option, and they have to rely on MCTs to take care of most of their diet. So usually experienced dietitian prescription is required, and the diet is organized in such a way that at least 40 to 50% of all the fats being consumed come from the MCT diet. And while MCTs are difficult to absorb, and they sometimes patients may have a lot of GI issues like diarrhea and irritability following taking MCT diet. Most patients usually are able to take it in significant amounts, and they can take it in the form of whole foods, which may include coconuts or oils, or it may include dairy products, or it may include MCT oil, which is essentially nothing but coconut oil, which can be added to salads, it can be added to vegetables, it can be added to protein shakes. And then certain commercial powders are also available, which can be blended in a lot of milk products like yogurts and curd, and they can also be consumed. So combination of these three usually is prescribed, and this leads to good absorption of fat. MCT diet usually helps in some of the patients. However, a lot of the patients do not respond, and then there are certain other options which have been tried. Now, all of these options are based on very small case series of usually less than 20 patients, and they have been tried and they work on different mechanisms. For example, the most commonly used drug here is octreotide, which can be used in diffuse intestinal lymphangiectasia. And the idea here is that while octreotide has many mechanisms, the most important is slowing the gut motility sufficiently so that food gets time to absorb, and the lymphatic leak is somehow counterbalanced by the amount of food absorbed by other pathways. And there could be induction and maintenance dose could be very simple 4 weekly subcutaneous injections, and it takes effect very soon, and most patients can be maintained on octreotide. Additional options include sirolimus and everolimus, and again these are drugs which mainly focus on the lymphangiogenesis per se, and the idea here is to block the lymphangiogenesis and promote the fat absorption by other pathways. And in combination with MCT diet, they may have some benefit. Tranexamic acid is also has also been used with some benefit. However, again, there is very little controlled data here that how beneficial they actually are. And some patients do respond and some patients do not respond. So the management algorithm in most of these patients would be to first confirm whether the patient has primary intestinal lymphangiectasia by doing endoscopies, imaging, and taking proper biopsies, and to specify the location of abnormal lymphatic channels, usually using advanced imaging modalities, including MR. If the lymphangiectasia is restricted to intestine only, whether it is a focal segment or a diffuse segment, the key to management is initial trial of dietary therapy, predominantly MCT diet. Once it fails, we move on to the other options such as intervention or surgery or if the disease is diffuse and intervention is not possible, we can try octreotide or sirolimus in these patients. And effectively, a lot of these patients may require intermittent nutritional support with multivitamins or fat soluble vitamins and essential fatty acids supplemented through intravenously. If all this fails, a lot of for very complicated patients, some TPN parenteral nutrition support may also be required. For other extensive locations, including mediastinum, pleural space, retroperitoneum, or in the extremities, again, dietary therapy may help, but interventional techniques may be helpful. So where do we stand on the radiological interventions over here? What is the role of lymphatic embolization, Deva sir, in such patients? How well can we do it?
So again, in this particular case where we are worried about protein leak through the duodenal hepatoduodenal lymphatics, we can we would try this transhepatic embolization of the hepatic lymphatics. But in our particular case, the problem with our case was that the direction of lymphatics was from the duodenum towards the liver. So even if you inject something through the liver and into the periportal location, it won't take care of the direction of the flow. So we are probably in the downstream area if you inject something into the periportal region. In fact, this is one of the collateral pathway which is getting opened up because of other issues, like the primary issue in our case must have been the absent or stenosed or non-functioning thoracic duct or the cisterna chyli, and that's the reason everything is being diverted towards liver. So in this, maybe we're not able to see the cisterna chyli. Otherwise, we would have puncture the cisterna chyli and would have seen what is the actual anatomy, what is the flow problems. And unfortunately, in this particular case, there was no visualization of cisterna chyli nor the visualization of thoracic duct. One blind area, as we said, is the mesenteric lymphatics. We were not able to find any lymph nodes in this particular patient sufficient enough to target the mesenteric lymphatics. So maybe, yeah, if we are able to find appropriate channels, transhepatic lymphatic embolization will most of the times take care of this issue, especially in patients where whether it is like patients with Fontan surgery or increased pressure related lymphangiectasia and proteinuria nephropathy. This particular technique would help, but not in this particular patient we had.
Okay, so the clinical course of primary intestinal lymphangiectasia is again very variable, and up to 60% of patients may respond with dietary therapy alone. And a lot of patients may have chronic relapsing disease course. A lot of disease associations have also been reported, and a lot of diseases may occur simultaneously in these patients. The most concerning could be a lymphoma, which has developed in up to 5% patients over a median 30 years follow-up. Opportunistic infections, including cutaneous warts, may also occur. And there is a need for close monitoring and follow-up in patients who have established complicated disease. However, there is again no defined screening strategy or follow-up routine that can be followed in such patients. So to summarize, lymphatic vessels are key for intestinal fat absorption and immune system maturation, and the gut has a very important role to play here. Intestinal lymphangiectasia per se is likely not uncommon. However, most patients we see who have whitish spots on endoscopy are in a compensated equilibrium state, and they usually do not require any treatment or any particular intervention. In patients, however, who have a malabsorption or anasaka, there is need for detailed evaluation, and there is a need to look if they for secondary disorder, and if there is any other primary disorder, we can treat it. For patients who have syndromic disorders, obviously a multidisciplinary management will be required, and this is perhaps beyond the scope of our discussion. The most sensitive test remains an endoscopic evaluation where we can possibly see the dilated lymphatic whitish channels, and the most specific test remains histopathology. However, imaging has a very important role to play, as Dr. Deva highlighted. The key management remains MCT diet, and additional interventions may be tried in selected cases, as and when the the situation allows. So with this, I would like to wrap up the talk for today. And if there are any additional questions, we can probably take up those. And
There's only one question in the chat box by Dr. Umang from Delhi, that if there's only duodenal lymphangiectasia, does APC or mucosal ablation by some other means help in decreasing the protein losing enteropathy?
yeah, so the key to note here is that the dilated lymphatics that we are seeing on endoscopy represent a tip of the iceberg. We are only seeing the mucosal lymphatics which have dilated or leaked. We are hardly seeing the real source of pathology, which is the either the incompetent lymphatic valves or the dilated lymphatic channels elsewhere, which are leading to leak in at that point. And to my understanding, there is no report as such of APC or any other mucosal therapy which can directly block the lymphatic channels right at the level. And if there's a focal lymphangioma, that can possibly be tackled, but I do not think that that is a very routine kind of picture.
So I think we come to the end of this master class. You all will agree that it was an excellent deliberations by Dr. Samagra and Dr. Deva, and such a rare disease has been made so simplified to understand by these two speakers. At the end, I'll also like to actually thank the delegates who have joined us for the master class, and the technical staff, and Nisha, my secretary, for arranging all this. So thank you, everyone. Thank you, Deva. Thank you so much.
Thank you, sir.
Thank you so much, sir. Thank you so much. Samaga, thank you.
Thank you, sir.
Thank you.
Okay.
Okay.
Bye, sir.
Okay.
Thank you.
Bye bye. Bye bye.
Bye.